Right, so good afternoon, everyone, and thank you for joining us today for our webinar on what's new in mantle cell lymphoma. My name's Liz. I'm one of the lymphoma care nurses, and I'll be your host for today's session. Kirsty, one of our other lymphoma care nurses, is here and will be facilitating our Q&A session after the presentation. And a big welcome to our presenter for today, Professor Tam. Before we dive in, I just have a few quick housekeeping items to mention. So we encourage your participation in today's session. If you have any questions, please put them into the Q&A function at the bottom of the screen, as the chat function will not be monitored, and we will have the Q&A at the end of the presentation. If you do miss anything or would like to rewatch the session, it is being recorded and will be uploaded to our website. This link will be sent to your email once this recording is available. If you have any technical issues during the webinar, please email nurse@lymphoma.org.au and we'll try and address this for you. So firstly, let's introduce our presenter for this afternoon, Professor Tam, a leading expert in lymphoma and an internationally recognised clinical haematologist. He currently heads the Lymphoma Service at Alfred Health and holds a professorship at Monash University. Prior to his current role, he served for over a decade as the disease group lead for low-grade lymphoma and CLL at Peter MacCallum Cancer Centre. A pioneer in the development of targeted therapies, he has also helped lead a study to help establish CAR T-cell therapy as a standard treatment for diffuse large B-cell lymphoma. With over 300 peer-reviewed publications and more than 27,000 citations, Professor Tam's research continues to shape the future of lymphoma care worldwide. I will now hand over to Con to share what's new in mantle cell lymphoma.
Thank you, Liz.
Thanks,
thanks very much for your kind invitation, and hello to everyone online today. So my brief is to provide some updates on this rare entity, mantle cell lymphoma, or MCL to its friends. So I would just want to start by explaining what, how we classify lymphoma and how we ended up with this funny name, mantle cell lymphoma. So lymphoma is a cancer of the white cells, predominantly in the lymph glands and in the bone marrow. And the first lymphoma ever described was described by Thomas Hodgkin. So there was Hodgkin's lymphoma. And rather unfortunate that every other lymphoma that's been described after that lymphoma is classified as non-Hodgkin's lymphoma, which is why we now have this very artificial divide between Hodgkin's lymphoma and non-Hodgkin's lymphoma, when really amongst the non-Hodgkin's lymphoma, there are many, many different types, and there's no real relationship between each of those forms within the non-Hodgkin's category. It's just that Hodgkin's came first, so everyone else will classify as non-Hodgkin's. So if you look at the lymphoma in total, around 1/3 of patients have Hodgkin lymphoma, and about 2/3 will have non-Hodgkin's lymphoma. And the non-Hodgkin's lymphoma have various different names listed here. We tend to think of them as either being indolent in nature. So some of these are such as marginal zone lymphoma, CLL, and follicular lymphoma. They tend to grow very slowly. They're often observed without any requirement for treatment, and many patients will die of old age or other problems before they run into trouble with these sort of indolent type lymphomas. On the other end of the spectrum are the aggressive lymphomas, which are all classified as non-Hodgkin's lymphoma. And you can see here that amongst the aggressive lymphomas in the very small slides here are the patients with mantle cell lymphoma. So mantle cell lymphoma inherits a bit of the characteristics of both the aggressive lymphoma as well as the indolent lymphomas. The indolent lymphomas grow very slowly, often do not require treatment for a very long time. Sometimes it never requires treatment. Aggressive lymphomas grow quite quickly. You generally have to treat these conditions within, pretty quickly after you get diagnosed with one of the aggressive lymphomas, because they do grow quickly and they are life-threatening. But the good thing about the aggressive lymphomas is that they tend to be very responsive to chemotherapy-based treatment. So at least in the case of diffuse large B-cell lymphoma, we can cure this condition with aggressive chemotherapy. Now, mantle cell lymphoma unfortunately inherits a bit of the worst of both worlds. So it tends to grow fairly quickly, and it's also fairly chemo resistant. So despite the application of very high doses of chemotherapy, which is a standard treatment these days, it doesn't tend to ever be cured. It tends to come back and needs to be retreated in the future. And it's more about how to juggle the tools that we have to try and give the patient the longest and the best quality of life possible when you have something like mantle cell lymphoma. So as I mentioned before, when I say the term non-Hodgkin's lymphoma, it's kind of like saying that I have, that you have a car. And of course, there are many different models of cars. You've got the really slow growing things like a Volkswagen, and then you've got the fast growing diseases like, the Maseratis. And as I mentioned before, the slow growing stuff don't tend to cause problems. They can be monitored. The fast growing stuff tends to be aggressive, needs to be treated very quickly, but they tend to be curable with aggressive chemotherapy. And mantle cell lymphoma just straddles between the two categories, being growing fairly quickly, but also not responding fully to treatment, with a tendency to come back after several years, even with the most aggressive types of chemotherapy. The other thing I want to just quickly touch on is the idea of staging. So this not only applies for mantle cell lymphoma, but really applies to all types of lymphoma in general. I know that in commission, you watch a movie, they often say, I've got like stage 4 cancer or stage 3 cancer. And a lot of people think that staging means how close you are to death. The closer you are, the higher the number, the closer you are to death. In fact, staging is not about how close you are to death. Staging actually describes where the cancer is. So stage 1 and stage 2 means that the cancer is localized to a particular area of the body, whereas for stage 3 and stage 4, you've got the cancer in multiple parts of the body. Now, you need to remember that most of our lymphomas, just like mantle cell lymphoma, is actually a disease of the blood, and blood goes everywhere. So most patients with mantle cell lymphoma, I would say over 95% or higher, will in fact be stage 3 or stage 4 at the time of diagnosis, because when we look on the scans and the bone marrow biopsies, we can find a tiny bit of lymphoma across most parts of the body. So it is high stage because it's in multiple places in the body. But that does not mean that you don't live for very long, because basically every patient with mantle cell lymphoma will have either stage 3 or stage 4 disease, and our treatment and all the outcomes of our treatment are basically for patients who have got stage 3 or stage 4 disease. We just have to make sure that we design our treatment that covers the entire body, because we know that there are lymphoma cells across multiple areas within the body. So what are some of the things that we use to predict how people would do with mantle cell lymphoma? There's a score called MIPI score, and what the MIPI score is, it gives you an estimate about how long someone is going to live for. Now, this is a survival curve, and what a survival curve is, it starts at 0 time, and you can see here that this is by month, so this is like 7 years out here, and it shows that at a given time how likely a patient in a category is likely to be alive. So in the lower curve here, you see that around half the patients have died by about 3 years, whereas on the upper curve here, that if you go beyond 7 years, that more than half the patients are still alive and doing all right. So the MIPI score is a tool that we use. It basically summarizes a number of factors. So the older you are, the higher the risk is. There's a thing called ECOG status, which is how fit someone is. So if you if you go and run 20 Ks a day and you're fully active on your feet and you do everything for yourself, then you've got an ECOG of 0 to 1. Whereas if you are bedbound because of fatigue and you can't look after yourself, then you've got ECOG status of 2 to 4. And across all different types of cancer, in general, the people who are very fit, who are able to look after themselves and are independent, do better than others. And you can see here that for mantle cell lymphoma, the ECOG is an important predictor of how well someone does. And then there's a couple of other things. There's a score called LDH, which is a blood marker, and a white cell count, which is another blood marker. But what you don't see on here is you don't see stage. So, someone can have stage 4 disease, but they can be young, have a really fit ECOG status, and have a normal LDH value and normal white cell count, and they can be on this top curve here where you can see that beyond 7 years, that most patients are still alive. Conversely, you can have someone who is only in stage 1 disease, but who is older, who's got a poor fitness level, and who's got abnormal blood markers, and they can be on this bottom curve here, where the average lifespan is only about 2.5 years. The other thing that we've started to realize that influences how the mantle cell behave is actually how the cells look. So this is something called blastoid morphology. And most patients with mantle cell lymphoma would not have this. And this is what the pathologists see when they look down in the microscope. So most patients, around 90%, will have small, nice-looking cells on the microscope, and we call that a classical type of mantle cell lymphoma. Whereas you can see here that some patients, around 10%, will have the cells being larger, more ugly, more unformed, and this is something called the blastoid or pleomorphic morphology, which basically, if the cells look more angry, they look nastier under the microscope, they're more likely to behave in a bad manner and not respond well to treatment. Lastly, probably the one factor that we use these days to determine how someone with mantle cell lymphoma will likely be treated in the long term is something called P53. So P53 is a gene that is important for response to chemotherapy. If you don't have a functional P53 gene, then your cancer is not going to respond well to chemotherapy. And indeed, you look at the survival curves here, the red curve are the results of patients without a P53, so these are people with normal P53s. And for the blue curves are the people where the P53 has been either mutated or has been deleted, so that the cancer does not have a functional P53 gene, which happens in about 1 in 5 cases in mantle cell lymphoma. And we know that people who carry this P53 gene without a P53 gene in mantle cell lymphoma, they have a much worse prognosis. And at least at my center, we treat these people in a completely different manner. We try to get people away from chemotherapy onto the new targeted drugs as early as possible. And if their patients have a good donor, we try to do a stem cell transplant or something called CAR T-cell treatment, which I'll go on a bit later. But of all the different factors to predict how someone does with mantle cell lymphoma, the most important thing is P53 status. All right, so how do we generally treat our patients with mantle cell lymphoma? So in general, we think about whether someone is fit for something called an autologous stem cell transplant. Now, I need to spend a moment to tell you what an autologous stem cell transplant is. Essentially, if you give someone a chemotherapy, as you know, some of you who have gone through chemotherapy, your blood counts get low when you have chemotherapy, and then you recover in time for the next dose of chemotherapy. But the major side effect of chemotherapy is the bone marrow being damaged and the bone marrow being suppressed. Now, there is a thing called autologous stem cell transplant, which is where we actually get your bone marrow cells and we put it in the bank, and then we can then give you a much bigger dose of chemotherapy than you will otherwise survive, and then rescue your body with those cells so that we don't kill off your bone marrow. So the only thing, when you hear the term autologous stem cell transplant, what it is just mega chemotherapy. It means we're going in there with a very big dose of chemotherapy, and we're using the stem cell transplant as a way to prevent your bone marrow from being wiped out. So the bone marrow is safe in the bank while we give you the high doses of chemotherapy, and then we rescue your body with that saved bone marrow. So a lot of you are thinking, oh my God, that sounds awful. And yes, it is pretty awful. And at least, in patients above the age around 70 to 75, it becomes not acceptable. The risk of dying and the risk of having a permanent disability becomes unacceptable. So we tend to think that patients who are younger, let's say younger than 65, 60, sometimes less than 70, may be transplant eligible. And we basically give patients a form of chemotherapy, the sort of chemotherapy that does make you lose hair. And then when the lymphoma has reduced to a very small amount, we come in with a transplant, which we like to think as a killing blow to try and knock out any cells that have survived the initial chemotherapy storm. Then the patients often take about 3 to 6 months to fully recover after the transplant, and we give people a maintenance antibody, which is a very low, something that doesn't have much side effects, but it just suppresses any surviving lymphoma long term. And after this sort of procedure, typically we would like to see patients stay in remission and get back to life for an average of around 7 to 10 years before the lymphoma comes back and needs to be treated. So we like to give younger patients this approach because it's very aggressive. It takes a lot of time in hospital. There's a lot of side effects, but it does give us maybe around 7 to 10 years of time without cancer, where the patient can get back to life and forget about the lymphoma for a while. Now, for older patients who are transplant ineligible, so if you're over the age of 70, 75, really we start to think that the transplant is not worth it. The risk of dying or suffering a disability from the transplant is too high. And we give a chemotherapy called BR, predominantly called bendamustine rituximab. And some of you may have had this chemotherapy. And then we will often give maintenance rituximab, so R being rituximab. And the R is like an antibody that's been engineered to attack cancer. It's not very strong in itself, but it's got very few side effects. So we like to give what we call maintenance rituximab, a dose every 2 to 3 months for about 2 years to just keep it under control. And typically you get probably around 4 years or 5 years of cancer-free time when you have this sort of regimen. Not as good as a transplant, but far fewer side effects. And then for patients who cannot tolerate even bendamustine rituximab, we can give an even gentler form of chemotherapy called RCVP, but this is a pretty unusual group of patients who cannot tolerate even the bendamustine type chemotherapy. And this is just a study to show a comparison between bendamustine rituximab, which is the standard chemotherapy we give now, compared to a treatment called R-CHOP. These are the proportion of patients still in remission over time, and you can see that patients who got the bendamustine rituximab are likely to have a longer remission duration, but more importantly, fewer side effects than patients who got CHOP, which is the reason why we choose this chemotherapy for most older patients. So what's new? Now, what's new is that the transplant may well be dead, which is everyone is celebrating around the world. I mean, I don't like doing transplants. Patients don't like transplants. And we've been trying to find ways to basically not do transplants if we can help it. So in the last few years, there's been a few studies to show that maybe we can get away without doing the transplants if we can do something else extra. Now, this is a study called Triangle. And Triangle is a big study that's been ran by the European group. And what it does is, this is a really complex figure, but concentrate on this box here. This is the autologous stem cell transplant. And what Triangle does is it adds a drug called ibrutinib. And ibrutinib is a targeted treatment, and it added in to the initial chemotherapy mix. And it asks the question, if we add ibrutinib into the initial chemotherapy mix, and then some of the patients then undergo a transplant, and others just have the ibrutinib added to chemotherapy and do not undergo the transplant, are the results equivalent? So when you add in a targeted drug like ibrutinib to the mix of the initial chemotherapy, can you forego the transplant? And this is the remission curve of people having the transplant in the green, as opposed to people who just took the ibrutinib without the transplant in the gray. And you can see here that they're basically identical. So a major message to come out from this clinical trial is that if you can get access to ibrutinib, which is a targeted therapy with some side effects, but in general, fairly mild side effects, and you can add it to your initial chemotherapy, even if the patient is young and fit, that the transplant is basically not useful. You do not prolong life or prolong control of the lymphoma with the transplant, you're just adding side effects. So I think that's the first trial that showed us that we can potentially avoid the transplant if we can get ibrutinib added to the chemotherapy. Now, that's a big if, because in this country, and at least in most countries around the world, outside of a clinical trial, you actually cannot get ibrutinib added to chemotherapy. So in this day and age, we're still giving chemotherapy, although I would like to see in the next few years the ability for the government to fund ibrutinib so we can add it to chemotherapy and avoid having to do this so fairly awful procedure to all our patients. The second study that looked at transplant, or rather getting rid of transplant, comes from Americans, and this is something that was presented, a few months ago. And what is a really complex study. But basically, what the Americans said is, okay, we can't get ibrutinib, but we've got this amazing test called a minimal residual disease test, or MRD test. And what the MRD test does is it looks for surviving cancer at a very high resolution. So the scans are all negative, the bone marrow tests are all negative, but the MRD test looks for cancer at the level of 1 in a million cells. So the Americans asked, if our patients after the chemotherapy have had such a great response that we can't even find cancer cells at the rate of 1 in a million, is a transplant useful? And what they showed here in A and B is that if you get into such a good remission status after chemotherapy that we can't find anything on you, even at the special MRD test at 1 in a million cells, then the transplant is useless. So people who got A were people who got transplant, and B are the people who did not get transplant, and the outcome is identical. So once again, another clue that there are certain groups of patients where a transplant is not necessary. Now, what's the drawback? And we have started to apply that at my place at the Alfred, but a lot of places have not started to apply this. And the reason why is because the test to determine if there is any evidence of cancer at all, the test that has the 1 in a million sensitivity test, that costs around $5,000 to do. And that's not funded by the government and not funded by the state. So it has to be funded either by the patient or funded by the hospital department. So at least at the Alfred, we have taken the view that the transplant is a pretty toxic procedure, and that if a patient is otherwise in remission and is negative by this test called clonoSEQ, that we know that the transplant is going to be a procedure that just gives side effects without any good outcomes. We've decided to fund this test internally. Although in the longer term, once again, we would really like to see this test funded, because $5,000 in the context of avoiding a 2-week stay in hospital with multiple blood transfusions and multiple antibiotic use and a pretty high risk of going to intensive care. In the context of that, we're saving probably close to $1 million to $250,000 in medical care by doing a test that costs $5,000. But of course, the government doesn't think that way. Different pockets pay for the different things, but we'd like to see these tests come into fruition in the near future. So those two studies are in the people who would otherwise undergo transplant. If we can get ibrutinib added to chemotherapy, the transplant is not necessary. If we can't get ibrutinib added to chemotherapy and we can do this clonoSEQ test looking for minimal disease, the transplant is not necessary. That's something that we're starting to apply in the clinic. What about to the older patients? These are patients who get the bendamustine rituximab chemotherapy who do not undergo a transplant. So what's new for these patients? Well, there's been studies now where, similar to the younger patients, we've added in ibrutinib to the chemotherapy. So this is a randomized study where patients who are over 65 years of age were randomly assigned to either having bendamustine rituximab by itself and a placebo, or they got bendamustine rituximab plus ongoing ibrutinib. And this is a study called SHINE. And you can see here in the blue curve, which is the people who got both chemotherapy and ibrutinib, that they did better than people who got placebo plus standard chemotherapy. The problem with this study is that the difference is not dramatic. You can see here that they did better, but they only did slightly better. So, there's maybe about a 10% improvement in the chance of being in remission at a given time. And ibrutinib and drugs like ibrutinib are very often used when chemotherapy has stopped working. So in the normal circumstance, if you get bendamustine rituximab and you get, let's say, 4 years of remission and it comes back, then we'll usually put you on ibrutinib, one of the drugs like ibrutinib, which is a tablet. And then you usually get an extra, somewhere between 1 to 2 year control on ibrutinib. And it would seem that by combining everything all at once, that you don't actually get a dramatic difference in how long you stay in remission for, but you get all the side effects of combining the drugs together. So we actually think that you're better off getting bendamustine rituximab chemotherapy, and then when you relapse, then you can get the ibrutinib separately. So to have the two drugs given sequentially, you end up having less side effects, and probably the duration of controlling the lymphoma is going to be the same or maybe even longer by using the drugs sequentially. So in older patients, bendamustine rituximab is still the way to go in terms of initial chemotherapy. Now, I've mentioned the name ibrutinib a few times, and ibrutinib really belongs to a class of drugs called the BTK inhibitors. And these are tablet drugs that turn off a gene called BTK, which the cancer depends on to survive. And it's been in the press a fair bit because in the days before we had BTK inhibitors, if you stop responding to chemotherapy, basically the game's up. You know, you stop responding to chemotherapy, more chemotherapy will just give you side effects, but the cancer tends to not respond for very long or just grow despite chemotherapy. So the BTK inhibitors came around, I started using these drugs back in about 2012. So I've had about 13 years experience with these drugs, and they were really game changers. So patients who come in, they've had multiple forms of chemotherapy, they've stopped responding, you put them on ibrutinib and they come back a week later and everything's gone, like the lymphoma is in deep remission. So these are drugs which are now standardly given when the chemotherapy has stopped working, and they're actually funded in Australia. So in Australia, we're funded ibrutinib, acalabrutinib, and zanubrutinib. The main advantage of acalabrutinib and zanubrutinib is that they've got fewer side effects compared to ibrutinib. But really, this is a really game-changing class of drugs. Now, when the cancer develops resistance to these drugs, they develop a mutation at where the drug binds the BTK protein. Something is an area in the protein called cysteine 481. And there is now a bunch of new drugs on the right here, which actually bind the BTK at different points. And the important thing about these drugs are that they work when the ones in the pink stop working. So we'll go for the covalent binding BTK inhibitors first. And typically you will get remission of between 1 to 2 years. And then when the cancer develops resistance, we can often buy a bit more time by giving a non-covalent drug, which binds the same protein, but in a different area. And this is just summarizing the results of the standard drugs that we use, ibrutinib, acalabrutinib, and zanubrutinib. I'm very lucky to have had a strong association with both ibrutinib and zanubrutinib over time. And you can see here that the important number is the median PFS, which means the average time for which you stay in remission. And you can see here across the three drugs, you're getting roughly and this is in months. So you're getting roughly around 1 to 2 years of remission. But these drugs are not magical, that you do not stay in remission forever. The cancer will come back, but while you take the drugs, they do have very few side effects, and the cancer is completely suppressed, and people normally have a normal quality of life when they take these drugs. Just to show that acalabrutinib has a reduced risk of side effects compared to ibrutinib. So this is a head-to-head study comparing ibrutinib in yellow with acalabrutinib in pink. And what you see in here is the risk of developing complications. So this is a complication called atrial fibrillation, and this is the risk of getting high blood pressure. And if you're on ibrutinib, you're much more likely to get these side effects than compared to acalabrutinib. Now, if someone's had chemotherapy, then they had the covalent BTK inhibitors, and the lymphoma has come back, that is a pretty nasty situation. And that is a situation where in the days before we have the effective treatment that we have now, most patients, if chemotherapy has stopped working and the standard BTK inhibitors have stopped working, the median lifespan is only around 3 to 6 months, as shown in this study here. So I was very lucky to have actually developed a combination which is still not yet on the PBS for mantle cell. It is on the PBS for CLL, a related disease. But this is a combination of two drugs, ibrutinib and a second drug called venetoclax, which is a tablet. And what venetoclax does is these two work really well together to kill mantle cell lymphoma. And we did the first study in the world comparing these two drugs back in 2014, showed that the combination worked really well in mantle cell lymphoma. And then we did a randomized study where patients were randomly assigned to this combination versus ibrutinib by itself. So this study has shown in the green curve here that if you take the combination of the two drugs together, that you get a longer remission duration, even for people where there's a p53 abnormality. So I told you before that p53 is a very bad thing in mantle cell lymphoma. And you can see here that even with ibrutinib, which is a great drug, that you only get 12 months of remission. And with the combination, the remission duration doubles to about 2 years. And for patients without the p53 abnormality, so these are the good risk patients, you can see here that the combination is pretty magic. Unfortunately, the government has not, this is not a combination that's being funded in Australia for mantle cell lymphoma. It is funded for CLL. Although we've got clinical trials using second generation of these drugs at the moment in mantle cell lymphoma. And I do encourage you to think about having a clinical trial because you are getting really, really good combinations, the best drugs of what we have. And if you go on a clinical trial, it's for free. You get access to really good drugs, and you get the warm and fuzzy feeling that you're advancing medicine and helping other people. I mentioned pirtobrutinib. This is the drug that works when the traditional BTK inhibitors stop working. You can see here that this is a waterfall plot. This is the reduction in the size of the glands in individual patients. So each of these bars is an individual patient. And you can see that on pirtobrutinib, that even some of the patients in the dark blue, which is people who are resistant to traditional BTK inhibitors, that they do respond, but the problem is they don't respond for very long. They usually respond for around 6 months. Now, I'm going to switch tack to actually talk about CAR T cells, because really I think the biggest news in mantle cell lymphoma, at least in the past 5 years, is actually CAR T cells. And this is, we had chemotherapy, we had BTK inhibitors, we got ways of making our BTK inhibitors work better. But really, the thing that I think is a real game changer is actually CAR T cell, and that is now actually available in this country in people as what we call third line, meaning that you've had chemotherapy, it stopped working, you've had the tablet targeted therapy, it stopped working, then the government will fund CAR T cells to treat. So what are CAR T cells? And I think to understand CAR T cells, we need to understand the concept that the immune system is actually capable of destroying cancer. So our immune system, we know, destroys germs and infections. And once you've had an infection or a vaccine, you don't get that infection again because the immune system learns about that germ and stops it from coming back. What's not really appreciated by most people is that the immune system actually destroys cancer cells as well. So every day, our body generates hundreds of cancer cells. But those cancers, we don't break out in hundreds of cancers on a daily basis. And the reason why is because the healthy immune system goes around the body, they see these cancer cells emerge in our body, and they destroy them before we ever know about them. So in a way, when you get cancer, is because your immune system, for whatever reason, has stopped responding, cannot recognize the cancer and cannot destroy it. And the converse of that concept is that if you can import a new healthy immune system from someone else into your body, then that healthy immune system can kill cancer. And because it's an immune system and it stays on with an immune memory, it can basically cure the cancer, because every time the cancer tries to grow back, the new immune system will kill it. And that's what we do when we do a bone marrow transplant from a brother or sister or unrelated person. So when we do a bone marrow transplant from a brother, sister, or unrelated person, we're putting in a new immune system into the patient, which would then kill the cancer. It sounds great, but the problem with when you put a new immune system into someone is that that immune system may recognize the patient as being foreign and destroy the patient from the inside. And that's something called graft versus host disease, which is a really, really horrible condition to get, because the new immune system, not only does it destroy the cancer, it starts to eat up the patient from the inside. So for the longest time, the holy grail of what we do is how can we get the immune system to attack cancer, but without having it attack normal organs. And that's what CAR T cells are. So what CAR T cells are is it's a really clever genetic way of hijacking someone's immune system. So I can get a patient's immune system which, as you have already noted, does not recognize the mantle cell lymphoma, but I can genetically hijack it with viruses, and I can tell the immune system to recognize the mantle cell lymphoma, grow the immune system in the laboratory, and then reinfuse it into the patient, so that and then that immune system will then multiply several million times, kill off the cancer, and provide long-term immunity. So basically, if your immune system cannot recognize the lymphoma and kill it, we can force it to do it with something called CAR technology. And so this is from one of my movies, where basically the cop jumps in the back of the car and hijacks this car and say, I need you to chase the bad guys and kill the bad guys. And this is exactly what we're doing to the immune system in CAR T cells. Is we're saying to the immune cells, forget about germs. We need you to attack cancer. You do what we tell you to do. And this is a movie from one of my mates. So the green are the CAR T cells and the red are the cancer cells. And what you see is that the CAR T cells will basically make contact with cancer cell, strike it, release toxins, and kill it. And then CAR T cells will actually go and kill multiple cancers. So this is a CAR T cell here. It loads up, kills off this cancer cell, then travels to the next one and kills off the next cancer cell. So these are really amazing technologies. And when we do CAR T cells, what we do is we collect the patient's own immune system on a machine. This is like a patient donating CAR T cells on an apheresis machine. The cells then get sent off by Qantas to the US, where they're manufactured. The government pays the bill, which is approximately $500,000 to have the cells made. The cells then come back to us about 4 weeks later, and then we give a bit of chemotherapy to stop the body from rejecting the CAR T cells. We then infuse the CAR T cells in the patient, and then the cells grow and they start to eat up the cancer from the inside. They can cause fevers and other complications, which we monitor and treat. But 4 weeks after CAR T cells, what we hope to see is that the scans are completely normal and that the cancer is hopefully completely suppressed, if not cured. And at least for mantle cell lymphoma, the key study in CAR T cells has had some long-term follow-up. So this is the chance of being in remission long-term. And if you concentrate on the blue curve, these are patients who have had a complete remission to CAR T cells. And these are patients where previously you would expect them to only live about 3 months before CAR T cells. You can see here at the 4-year mark that most patients are in fact still in remission. Hopefully some of these patients will never relapse. So really it's a transformational technology. It's very expensive. It's very, very complex. There are only 8 CAR T cell centers in this country. I happen to work in one of them, but it is truly the way of the future. So with that, I hope I have not confused you with all the different options of mantle cell lymphoma out there. I'm very happy to take questions. Thank you for listening.
Thank you very much, Con. That was a very thorough overview of mantle cell lymphoma and current and future treatment options. I'll now hand over to Kirsty, who has been monitoring some incoming questions we have received.
Okay, hi. So we've got a couple of questions here. The first one is, my own mantle cell lymphoma had a high Ki-67 score and high MIPI risk. Are these still considered the best indicators of prognosis, or are there any newer ways of assessing individual risk?
Yep. So the MIPI score, in a way, is when you look at the cells and we do a special stain to see how fast the cells are growing. So a high MIPI score means that the lymphoma is growing faster, and a low MIPI score means that the lymphoma doesn't grow as fast. And traditionally, that is a prognostic factor in mantle cell lymphoma. So people who've got high MIPI score do have shorter responses to chemotherapy, shorter responses to targeted therapy, and has more aggressive disease. But it doesn't change what we do. So we still give the best available treatment option, which in this day and age is still chemotherapy, and if you're young enough, a stem cell transplant. Probably the most important risk, as I mentioned, is something called P53. And that, unfortunately, is not something that everyone has been tested for, because I think the knowledge is still filtering through the ranks about P53. If you have a P53 mutation, then it makes a big difference, because it means that we probably should avoid the transplant altogether, and we should try and minimize the chemotherapy, and we should move on to like CAR T cells and the targeted treatment at an early stage, because we know that the cancer will not respond well to chemotherapy-based treatment.
Okay, thank you. We have another question as well. What promising trials are currently recruiting for mantle cell lymphoma patients, either in remission or at early signs of relapse?
Yeah, so there's a couple. So there is a study at the moment that is combining, remember I mentioned ibrutinib plus venetoclax being a really good combination. There is a combination of the second generation ibrutinib, zanubrutinib, and the second generation venetoclax, sonrotoclax, in combination. And at least in our experience, the response rates are extremely high in that combination. But there's a clinical trial. There are also multiple clinical trials of new CAR T cell constructs. These are CAR T cells that have been either manufactured from a healthy donor, or CAR T cells that are slightly different. So CAR T cells target, for example, 2 targets instead of 1. So a lot of them are recruiting in mantle cell. There is a study called Goldilocks around Australia, which is combining the new BTK inhibitor, the pirtobrutinib, with something called glofitamab, which is glofitamab is a bispecific antibody. So it binds the patient's normal immune system with one hand, and it grabs the cancer with the other, and it forces them together. It's kind of like doing CAR T cells without doing CAR T cells. And so that's trial going on. Yeah, those are probably the major trials going on at the moment in relapsed mantle cell around the country.
Okay, thanks, Con. So the next question, is there increasing concern about the extent of neurological complications from CAR T treatment?
Yes, there is. So I didn't go into that in detail for this presentation, but when we give CAR T cell treatment, one of the things that we worry about is the patients can get confused as the cells grow. So as the cells grow, you think about the last time you had, let's say, a really bad case of influenza or cold, and you had high fevers and your thinking's not clear. Well, think about that, but magnify in a major way. As the cells grow, they secrete chemicals. The chemicals cause high fever, and it can cause a patient to be confused. And it can be as mild as just being a little bit confused but unpleasant, to being unconscious and having seizures and going to intensive care. And that's what we call the neurotoxicity of CAR T cells, which can be very scary. And especially in the case of mantle cell, the risk is higher compared to other diseases. So we monitor patients very carefully. And it's actually not, at least in our view, it is the most important side effect of mantle cell lymphoma treatment. But in terms of like fatalities from CAR T cells, it's actually not from the neurotoxicity. It's from the fact that if you get neurotoxicity, we have to give you a lot of treatment with something called steroids, dexamethasone. And when you have a lot of steroids given over a long period of time, that weakens your body's immune system and it makes you susceptible to infection. So it's actually not the neurotoxicity that is the risk to a patient. It's the fact that we've got very blunt treatment for you to treat neurotoxicity, and patients are exposed to quite toxic doses of steroids for long term.
Okay, thank you for that answer. So next question, how long before CAR T cells are manufactured in Australia and become more affordable?
So we manufactured CAR T cells in Australia for a while. So Peter Mac has a CAR T cell facility, and actually manufactured T-cell for Roche for a while, and actually did a really good job with that. And then Roche made a commercial decision to not proceed the contract, which is why we don't currently make any of the commercial CAR T cells in this country. But they're actually not that hard to make. And there are actually off-the-shelf kits that allow you to make them. So at least at my place and also at Peter Mac, we're now starting clinical trials of these also, locally manufactured CAR T cells using these sort of kits that companies have put out. So I suspect it won't be long before we start making them in this country for our own use. But obviously, we need to do the trials to show that they're just as safe as the commercial CAR T cells, and hopefully they work better. In terms of access, I mean, if you meet an indication for funded CAR T cells, you don't pay any money. It costs the taxpayer a lot of money to make those. But there are certainly patients where they don't meet the criteria for CAR T cells, and they have to try and find $500,000, which is really an outrageous amount of money in anyone's case to pay for it. And it'd be really nice in the future if we can get the cost down to, let's say, $50,000 or $25,000 because of local manufacturer.
Okay, thank you. Next question. You mentioned 7 to 10 years before relapse if you have a transplant. Is that measured from the time of transplant or from the end of the period of maintenance rituximab?
Usually from the transplant, because those numbers are derived in the studies before we added in maintenance rituximab. Now, maintenance rituximab tends to prolong that time by another 2 or 3 years. So, we are talking multi-years of remission here.
Okay, and this next question, why does the MIPI score not take TP53 deletion into account?
Because it was derived before we realized how important P53 was, essentially. But now that we actually know how important P53 is, we kind of go through the motion of calculating the MIPI score. But it actually doesn't change my decision making. What changes my decision making is a P53.
Okay, thank you. So next question, would like to double check when we're discussing stem cell transplant and relapse 7 to 10 year, was that referring to mantle cell or does it include diffuse large B cell also?
Yep. So for the audience, there's a disease called diffuse large B cell lymphoma, which is also treated with a stem cell transplant. Now, mantle cell lymphoma, I'm talking about mantle cell lymphoma because mantle cell lymphoma, we don't think will ever go away with a transplant. So average of 7 to 10 years, but if you follow someone all the way up to 20 years, probably everyone will relapse at some point if you've got mantle cell lymphoma. Diffuse large B cell lymphoma is a completely different kettle of fish. This is a cancer that we can potentially cure with the high doses of chemotherapy given for transplant. So we think that roughly around 35 to 45% of patients who have a stem cell transplant for diffuse large B cell lymphoma, especially to get to the 5-year mark without relapse, are probably cured.
Okay, so now we have a question for the older patient, 76 years and at 5 years remission on zanubrutinib. If or when this ends, what treatment might be considered at this point in time? Thank you.
So that's a pretty good outcome on zanubrutinib because most patients, have about on average a 2 to 3 year remission. But average is average, right? The average income in Australia is $80,000. You've got people who make way more than that. So Rosemary, you're just very fortunate to be in a good response category. I don't know how long it's going to last. I hope quite a bit longer. I still have occasional patients from the initial zanubrutinib study back in 2013 who are still in remission. So you do get some patients who are doing really well on the drug. If you do relapse, even at the age of 76, assuming that you've had chemotherapy in the past, we will be considering you for CAR T cells, assuming that you are still in good health in general.
Okay, a few more questions here. Thank you. So next one, why would a patient have a reinfusion of their own stem cells rather than a donor transplant?
Yep. So this goes back to my point about having something called autologous stem cell transplant, which is when you use your own cells, as opposed to a donor transplant from someone who is, either a brother, sister, or someone who's unrelated. So when you have your own stem cell infusion, the immune system does not change. So the chance of the immune system eating you up from the inside of graft versus host disease is basically zero. Whereas if you have an infusion from a donor, there's a pretty good risk that the immune system will recognize you as being foreign and cause really nasty graft-versus-host disease. So, but then it's a double-edged sword. When you have a new immune system, the chance of being cured from lymphoma is also much higher because the immune system can destroy lymphoma. Whereas when you have your own cells, in the case of mantle cell lymphoma, we know that that's not enough to cure. We know that the lymphoma will go away for a while, but it will come back in the future.
Okay, so I am on maintenance rituximab and have had a number of respiratory viruses. Is this to be expected?
Yeah, it is. So I think one thing that COVID has really taught us is that rituximab and the other drugs like rituximab probably are not as benign as we think it is. So, in the pre-COVID days, we usually think, oh yeah, rituximab, is a free shot and go. We put everyone on it. But since COVID, we realized that, for example, that one of the major predictors of dying from COVID is actually being on rituximab. And that probably all of these drugs do impair the patient's ability to fight minor viruses. And usually the people don't end up in the hospital, but they just spend their entire life in misery with recurrent viral infections. Sometimes I check the patient's immunoglobulin levels, and if your normal antibody levels are low, you can get immunoglobulin replacements either in the vein or under the skin, and sometimes that will take away a lot of those infections. Other times, I've had patients that I just have to stop maintenance rituximab. Their life is just such a misery that it's not worth the price.
Okay, and is there any other current mantle cell lymphoma treatments that make you ineligible for CAR T?
Not really. So the only thing that we need to be a bit careful about is CAR T recognizes mantle cell lymphoma by a marker called CD19 on the mantle cell lymphoma cells. And there are no treatment that we use at the moment that would actually erase CD19 from the mantle cell lymphoma cell. In other diseases, you have got other ways. You have got antibodies that target CD19 and other things that can potentially, I guess, give the cancer a prelude about what's coming. And then the cancer sometimes loses the CD19 expression, which means that the CAR T cells cannot recognize the lymphoma. But that's not really a problem for mantle cell lymphoma, thankfully, because none of those other CD19 drugs have made it to mantle cell just yet.
Okay, and last question, Con, why is mantle cell lymphoma so much more difficult to treat than other lymphomas?
That's a $1 million question. And we don't fully understand why mantle cell lymphoma is such a difficult beast. It is genetically reasonably complex, so usually there are a number of genetic abnormalities within mantle cell. But we just think that it just happens to hit the right combination of genetic abnormalities that make it grow pretty fast, but then makes it pretty chemotherapy resistant, which is really the worst of both worlds. So small disease, it's not very common, but it causes us a lot of headaches, but equally, it also promotes a lot of research because we want to do better. If we're doing really well in lymphoma, then we won't bother to research it. So mantle cell lymphoma has been a field that we've done a lot of intensive research into for that particular reason.
Okay, so there's still a couple more questions, if that's okay.
Sure.
If we've got, I've had 2 years of immunotherapy post stem cell transplant.
Yep.
Can I have that ongoing to keep mantle cell lymphoma sleeping?
So the key study of mantle cell lymphoma, maintenance rituximab, there's a couple, but in general, those studies have kept the duration of remission of maintenance to 2 to 3 years, which is what we generally recommend. The reason why is that nothing will work forever. So even if you continue rituximab forever, it's not going to work forever. The lymphoma will develop resistance to it eventually. And although there's no data out there, we don't think anything more than 2 or 3 years is going to give us much bang for the buck. What it does do, though, is it does greatly increase the risk of the normal immune system being damaged and the immunoglobulin levels being low and frequent viral infections, as Stephen has pointed out before. So we've tended to stop it after about 2 to 3 years, say the job's done, and then monitor, knowing that there are good treatments down the road and we can reuse rituximab in the future.
Okay, thank you. Last question. I think we have time for one more question.
Yeah.
How long does it take for B cells to get back to normal levels following stem cell transplant and or maintenance rituximab?
So normal transplants are usually not bad. Probably around 6 to 12 months you get the B cells return to normal. Maintenance rituximab is a different question. Probably, the risk of, let's say, reactivation of things like hepatitis B last around 2 years after finishing maintenance rituximab. So I think that the answer is around 2 years before the B cells return back to normal on average.
Okay, thank you.
All right, I think that finishes our questions. So thank you all for attending the webinar this afternoon. Yep. We really appreciate your time and hope that you've all been able to increase your knowledge on mantle cell lymphoma and have some of your questions answered. Thank you once again to Professor Tam for being with us today, sharing your knowledge and expertise. We really appreciate you giving up your time also. If you have any questions regarding your lymphoma diagnosis, treatment, or are needing more information or support, please reach out to us either via our email nurse@lymphoma.org.au or on a nurse support line on 1800 953 081. We will pop that in the chat for you as well. We would love to see you again in any of our upcoming online or in-person support groups or future webinars and events. So keep an eye on our emails and events calendar for future dates. And that's it. Thank you very much. Thanks, Con.
Thank you. Bye, guys.
All right. Bye.
Thank you.